This is a video demonstration of a 4-level minimally invasive lateral interbody fusion technique for treatment of degenerative scoliosis. The patient is a 63-year-old male with past medical history of aortic valve replacement on Coumadin who presents with intractable low back pain and evidence of deformity progression on serial imaging. His preoperative 36-inch x-rays reveal coronal imbalance, lumbar hypolordosis, and mild sagittal imbalance. The patient is placed on a bendable operating table in a lateral decubitus position with the table flexed in order to open up the space between the 12th rib and the iliac crest. The patient's position is secured with tape and all pressure points are well padded. Next, the intervertebral spaces of L1-2, L2-3, L3-4, and L4-5 are confirmed by placing a K-wire on the skin and marking the levels using fluoroscopic guidance. A longitudinal skin incision is made overlying the marked areas. Manual blunt dissection is performed to traverse the layers of the abdominal muscles and gradually develop the retroperitoneal space. Special attention is taken to prevent injury to the nerves that travel within the layers of the abdominal muscle. Therefore, we do not recommend using monopolar cautery for this part of the approach. Here we are demonstrating the nerves within the abdominal wall in more detail. The index finger is used to palpate the psoas muscle. The initial dilator is placed through the retroperitoneal space. The dilator is docked on the target disc level using fluoroscopic guidance. The K-wire cannot be placed until lateral fluoroscopy confirms placement of the dilator over the disc space. The dilator is then connected to a dynamic EMG stimulation clip, and live EMG is used while advancing the dilator through the psoas muscle. The EMG helps the surgeon navigate away from the nerves of the lumbar plexus.
And then rotate it.
Next, a K-wire is introduced through the dilator into the disc space to secure the dilator. Serial dilators are subsequently introduced. Live EMG is used with each dilator insertion. Then the expandable tubular retractor is inserted. The expandable retractor is then secured to the table using the articulating arm. The articulating arm should be positioned so that it constantly applies downward force on the retractor. Retractor handles must be parallel to the floor and not rotated in any direction. The two ends of the bifurcated light cable are inserted down the left and right retractor blade. The retractor blades are expanded to expose the disc space. It is important to avoid overexpanding the retractor to decrease psoas trauma and traction on the lumbar plexus. For this reason, the retractor is opened 6 to 7 clicks in the AP direction and 2 clicks in the superior-inferior direction. An intradiscal shim is placed into the disc to further stabilize the retractor. The position of the retractor blades is then confirmed using fluoroscopy. The residual psoas muscle tissue at the base of the retractor is then retracted to expose the underlying disc space. An EMG probe can be used to confirm the absence of any nerves. Next, the disc space is incised with an annulotomy knife. The disc material is removed using pituitary rongeurs. A Cobb elevator is used to strip the disc off the end plates. Special care should be taken to preserve end plate integrity with the Cobb. The Cobb elevator is passed completely through the contralateral annulus to better distract the collapsed disc space and to correct the segmental coronal alignment. The discectomy and end plate preparation is completed with a box disc cutter, end plate scraper, and pituitary rongeurs. The interbody slides are used to facilitate insertion of the interbody cage and help protect the end plates from injury. The advancement of the implant is monitored by fluoroscopy to confirm the proper implant position. When removing the retractor, visual inspection is performed to look for areas of bleeding. The skin is closed in typical standard fashion. Postoperative X-rays reveal correction of coronal balance while sagittal balance is maintained.
How are you doing today?
I'm doing fine, thank you.
What'd you have done?
I had a minimally invasive standalone lateral fusion for scoliosis.
How long ago was that?
Approximately 6 months.
Okay. How is your back pain now since the surgery?
Much better.
Okay. You just finished a course of physical therapy?
Correct.
Okay. And are you back to your activities of daily living now?
Well, I really haven't stopped. Yeah, but yes.
Outstanding. Can we see you walk for a second, please?
Sure.